So today's about pulmonary ventilation, so just the act of breathing. And then we need to discuss what controls that rate and depth of breathing, how gases are transported, and then we'll finish off talking about spirometry and respiratory disease. This one video is jam-packed of information. It is a great review video or a great introduction video.
Pulmonary ventilation, commonly referred to as breathing, is the process of air flowing in and out of the lungs during inspiration and expiration. The air movements are governed by the principles of gas laws. Basically, air flows from higher to lower pressure. Pressure within a cavity increases when its volume decreases, and vice versa. Volume of a given amount of gas increases with increased temperature. At rest, in between breaths, the pressure inside the lungs, or intrapulmonary pressure, equals the pressure outside of the body, or atmospheric pressure. When discussing respiratory pressures, this is generally referred to as a relative pressure of zero. This is because what matters is the difference between the two pressures, not their absolute values. Thus, a negative pressure is a pressure below atmospheric, while a positive pressure is above atmospheric. The lungs are covered in a double-layer membrane, which forms a thin space surrounding the lungs called the pleural cavity. The pressure within the pleural cavity, or intrapleural pressure, is normally negative. This negative pressure acts like a suction to keep the lungs inflated. If this becomes zero, such as in the case of pneumothorax, when the chest wall is punctured and the pleural cavity has the same pressure as the outside air, the lung would collapse. Pulmonary ventilation is achieved by rhythmically changing the volume of the thoracic cavity. During inspiration, the diaphragm and the external intercostal muscles contract, expanding the thoracic cavity and the lungs. This increase in volume results in a decrease in pressure, causing outside air to flow in. Another factor that helps to inflate the lungs is the warming of the inhaled air. This effect is most notable on a cool day when the temperature outside is significantly lower. The inhaled air increases in volume as it warms up inside the body and inflates the lungs, further facilitating inhalation. While inspiration requires muscular contraction and hence energy expenditure, expiration during quiet breathing is a passive process. As the diaphragm returns to its original position and the muscles relax, thoracic and lung volumes decrease and pressures increase, pushing air out of the lungs. Quiet expiration relies therefore on the elasticity of the lungs and ribcage, their ability to spring back to the original dimensions. Conditions that reduce pulmonary elasticity, such as emphysema, can cause difficulty exhaling. Deep breathing requires more forceful contractions of the diaphragm, intercostal muscles, and involves additional muscles to produce larger changes in the thoracic volume. Deep expiration, unlike quiet expiration, is an active process. Another factor that affects ventilation is the resistance to airflow, which exists within the lung tissues and in the airways. Lung compliance refers to the ease with which the lungs expand. Healthy lungs normally have high compliance, low resistance, like a thin balloon, easy to inflate. Lung compliance is reduced when the lungs become stiff, in conditions that cause scarring of tissues or fibrosis. In this case, the lung turns into a thick balloon, harder to inflate. Diseases that narrow the airways, such as asthma, increase resistance, making it harder to breathe. The airways may also dilate or constrict in response to various factors. For example, parasympathetic stimulation and histamine typically narrow the bronchioles, increase resistance, and decrease airflow, while epinephrine, a hormone released during exercises, dilates bronchioles and thereby increases airflow.
So previously we learned that the lungs, they're cone-shaped, they're in the thoracic cavity. The tissue itself, so not the airways, is very spongy and very elastic. Each lung is going to be contained in its own serous membrane, and if you remember, serous membranes have two parts of them. It's a double membrane with a space in between. So attached to the thoracic wall is going to be the parietal pleura, and then on the organ itself is going to be the visceral pleura. The space in between is the pleural cavity, and it is these membranes that's going to secrete the serous fluid. And the fluid is going to provide lubrication, so when the lungs expand, they glide seamlessly, like you don't feel the lungs expanding or scraping against the thoracic wall, and it's so that they can work in a friction-free environment. The other thing is that this attraction of the parietal pleura to the visceral pleura, because of the cohesion of the pleural fluid, that's going to keep our lungs inflated. Okay, it's creating surface tension, so wherever the thoracic wall goes, a compliant lung will go with it. And so all we have to do to breathe is move our thoracic wall and change the volume of air inside the lungs. And so a compliant lung is a stretchy lung, and so it's going to go wherever the thoracic wall goes. Of course, there's some homeostatic imbalances involved. So just like we had pericarditis, of course, it's not called pleuritis, it's called pleurisy instead, but pleurisy is inflammation of the pleurae. And normal breath sounds sound like this. So you can hear inspiration and expiration. You also hear the heartbeat in there as well. And then someone that had pleurisy, you have to think that parietal is rubbing against that visceral pleura. And so just like when we listen to heart sounds, whenever there's rubbing, you can hear that static or that friction. So that's a pleural friction rub. Other problems, anything that breaks this surface tension. So if anything gets in this pleural space, and it could be air, it could be blood, it could be fluid, that is going to break that surface tension. And so pleural effusion is something that can also happen. And what you can get with this is a collapsed lung or atelectasis. Okay, so short answer, we are negative pressure breathers. All we have to do is to drop the pressure inside our lungs below atmospheric pressure. Air has weight to it and provides pressure, and atmospheric pressure at sea level is 760 millimeters of mercury. So there's some laws governing gases, and Boyle's law has to do with the relationship between pressure and volume. This is not blood volume, okay? So just, it's going to be different. So we're talking air, all right? And as when we talk about air, if there is an increase in volume, then that is going to lower pressure. If we compress it, so now you have a smaller volume, that's going to increase pressure. Okay, so as volume goes down, pressure increases. As volume goes up, pressure decreases. Okay, and so like I said, we're going to use this with our respiratory muscles and change the volume inside of the lungs, inside the airways. All right, if you've ever used a syringe or seen one, it's just like that. Okay, so just kind of keep that in your mind. We are going to use our respiratory muscles when we want to inspire to increase the volume inside of the airways, and therefore air will flow in. So just like if you were drawing up fluid with a syringe, it's the same idea. Then when we want to expire, all we have to do is reduce that volume, and then air will leave based on pressures. Okay, so this is a great picture. All right, so there's some pressures, and usually it's represented either across a membrane or in relation to atmospheric pressure. And like I said, this surface tension Okay, if we were to measure the pressure across this wall, is this intrapleural, so intra means between the pleura, pressure has to remain negative in order for our lungs to stay inflated. Okay, like I said, it's that surface tension that's keeping our lungs against the chest wall. All right, so for inspiration, this has to do with, I kind of say, two opposing forces, right? So we've got that surface tension, so the lungs are going to stay attached to the thoracic wall. And then two, the lungs are compliant when they're in a state of health, so they're nice and stretchy. Like I said, so we are just going to use our muscles of inspiration. So the diaphragm, which is a dome-shaped muscle, I wear my shirt today, is just going to flatten out. We're going to expand our chest wall using the external intercostals, okay, changing that space, and assuming that the lungs go right along with it, then we're going to get an intake of air. So compliance is that ease of expansion, stretchiness, however you want to think of that word. If someone's compliant, they just go along with the flow, right? Not only lung tissue, because we're going to talk about some disorders, it's also the thoracic wall itself. Okay, so there's some structural deformities that can also impact breathing. When it comes time to expire, and this is at rest, by the way, when it comes time to expire, all we have to do is just relax the muscles that we used on inspiration. So then we relax the diaphragm, and it's going to dome up. We relax those external intercostals, and the rib cage goes back to be a smaller size. And this is going to decrease the volume inside the lungs, and therefore air will exit out. And like I said, we don't have to drop it or raise it a lot. Just 1 millimeter of mercury is enough to get air to move. Okay, so it's just passive in what's called quiet breathing or eupnea. Expiration doesn't cost us any ATP. Okay, we spend a little energy breathing. So inspiration is the diaphragm, external intercostals, and then expiration at rest, all we have to do is relax, which doesn't cost us anything. And that's the elastic recoil of the lungs that's going to be responsible for that decreasing the volume inside the lungs. And then also the abdominal organs have recoil as well. So they're going to help dome up that diaphragm again. So this process of breathing, so inspiration and expiration. On that expiration, lungs want to assume the smallest space. Like I said, they're highly elastic. Also, we have these tiny little air spaces, so the alveoli, this is our respiratory membrane, and we learned about surfactant. So surfactant is a lipoprotein that's going to break this surface tension. We want this surface tension between the pleura, but we don't want the alveoli to collapse. Okay, and we talked about infant respiratory distress syndrome, and they don't have the ability to make the surfactant. So on expiration, the alveoli, one wall will stick to the other wall. Okay, and so that's distress. And so here's a normal lung. So open air spaces show up dark on an x-ray. And then someone in respiratory distress syndrome, and we talked about infant respiratory distress in particular, then that would appear white. There's no more open spaces. Okay, so we need that surfactant to break the surface tension in the air sacs. So problems, I already told you, anything that gets into this space, the pleural cavity, can cause the lung to collapse. And it doesn't have to be the whole lung, it just be a segment of the lung, it could be a lobe of the lung. And so compressive types of atelectasis, which is a collapsed lung, can be blood, air, or fluid. You can also have a collapsing lung if there are blocked airways, that can do it. And then two, from scarring, or they just call it contraction, so cancer or lung scarring from fibrosis can also cause a collapse of a lung. And so atelectasis is when alveoli can't inflate and the lung collapses. And like I said, so it's just kind of the pretty picture. So quiet inspiration, like I said, we're negative pressure breathers. All we have to do is change the volume inside of the lungs, inside of the airways, and air will flow in. So we just need to drop it just a little bit, and air always moves from higher pressure to lower pressure. So the diaphragm and the external intercostals are always used on inspiration. This nerve signal, since these are skeletal muscles, comes from the phrenic nerve, and and they're going to innervate, that's going to innervate the diaphragm. And then we also have nerves going to the external intercostals. Okay, so just you learned about the muscular system, motor neurons, stimulates, we get muscle contraction. When we are at rest, not doing anything, expiration, blowing out, it's just a passive process. We chest relax the diaphragm, we chest relax the external intercostals, and that surface tension, when the lungs elastically pull, is just going to pull those lungs closer or smaller, and that's going to lower the volume, increase the pressure above atmospheric, and air leaves. And there it is in words for you. All right. We're not always at rest, though. Okay, and I have this picture, just what we're going to find out when we talk about increased rate and depth of breathing. We will more increase our depth of breath than our rate. I'm not saying we don't increase our rate, but we don't do that, right? Go for a run today. You know, if you're a runner, good for you. If you're not a runner, go for a run today. We're going to increase our volume greater when we need more air to move, okay? And then we can compress more when we need to exhale more volume. And so that's when we're going to recruit some accessory muscles, okay? We're going to use more muscles for forced inspiration and expiration. Okay, so forceful breathing, accessory muscles. And if it's forceful breathing to meet metabolic needs, it's called hyperpnea. So forced inspiration, if you place your hands on your neck and take a big breath in, you're going to feel a lot of contraction in your neck, the sternocleidomastoids. You have your scalenes there. They're going to get recruited, and they're going to help lift up on the upper ribs and the sternum to increase that way. And then also for expiration, when we want to blow out, deep to the external intercostals, the internal intercostals, and their fibers go the opposite way. So we can force more air out, and then put your hands on your abdomen when you blow out. All your abdominal grip is also going to aid that. Okay, so if you remember, you've got your rectus abdominis, you got your internal, external, transverse abdominis, and then I went the wrong way with my hands. Oh, I screwed up my hand signals. Rectus abdominis, upright. There you go, the one in the middle, the six-pack, all right? External intercostals, internal intercostals, and then transverse abdominis. They're much better the second time around. Online people, sorry you didn't see my hand motions. All right, so eupnea, U means true, nia always means breath. So when someone is just quiet, unlabored breathing, respiration rate is 12 to 20 breaths per minute. If somebody goes below that or over 25, then somebody probably has a problem with that. Infants have a higher resting rate of respiration. They're more like 30 to 50. Hyperpnea, that's when we're going to have our forced breathing. We're going to use those accessory muscles. That's to meet metabolic needs. Dys always means bad. So dyspnea is difficult or labored breathing. How do
you say that first word?
Eupnea. Eupnea. Yeah, hyperpnea, dyspnea, and then sleep apnea is when there's spells of no breathing during sleep. Yeah, and there's just kind of remember, slow, deep breathing is much more efficient for effective ventilation. So if a patient is breathing very shallowly, there's not a lot of air getting to the respiratory zone, because we just learned about that anatomical dead space, all those airways that we colored, nothing's happening in those airways until you get to the alveoli. So a shallow breath doesn't get the oxygen to the respiratory zone.